The information provided in this video is for educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have seen in this presentation. Your hands are shaking so badly you can barely dial the number. Or maybe you're the one in the back of the car, watching the streetlights blur together, the silence so loud it's screaming. Someone you love, or maybe it's you, is in the middle of a mental health crisis. The world is spinning off its axis, and all you know is that you need help, right now. So you go to the one place you're told to go, the emergency room, and that's where the nightmare often gets complicated. You're thrown into a system you don't understand, a world of locked doors, hushed conversations, and a dizzying storm of acronyms. A nurse mentions an IOP. A doctor talks about a PHP. Someone hands you a clipboard with information about an RTC. It feels like a foreign language, and you're expected to become fluent in the middle of a Category 5 hurricane. This confusion, this feeling of being lost in a labyrinth at the worst possible moment of your life, is terrifyingly common. Nearly 1 in 5 American adults lives with a mental illness. Millions of us, our friends, our parents, our children, will at some point need a level of care that goes beyond a weekly therapy session. Yet the system designed to provide that care is one of the most opaque, fragmented, and misunderstood parts of our entire healthcare landscape. When you're in crisis, you don't have time to research the difference between a state hospital and a private psychiatric facility. You don't have the energy to decode what step-down care means. You're just trying to survive. This is the guide you need. This is the roadmap I wish someone had given my family. We are going to pull back the curtain on the entire system of mental health institutions in the United States. We will walk through every single level of care, from the moment you enter that emergency room to long-term residential treatment. We're going to define all those confusing acronyms. We'll break down what each facility actually does, who it's for, the philosophy behind its treatment, and critically, how it's typically paid for. By the time we're done, you will no longer be a passive passenger in this process. You will be an informed navigator, capable of advocating for yourself or your loved one, asking the right questions, and making the best possible decisions when it matters most. You will have a map for the labyrinth. So let's start where most crises begin, the emergency room. For mental health, the ER serves as the system's massive and often overwhelmed triage center. It is not designed for long-term treatment. Its primary function is medical stabilization and assessment. Think of it like the first responders at a major accident. Their job is to stop the immediate bleeding, assess the vital signs, and determine if the person is an imminent danger to themselves or to others. This is a critical point. The main question being asked in the ER is about safety. Is this person safe to go home? If the answer is no, that's when the process of an involuntary hold, often called a psychiatric hold, begins. You've probably heard of these from movies or TV shows. In California, it's a 5150. In Florida, it's the Baker Act. Nearly every state has its own name and specific laws, but the general principle is the same. A person can be held against their will for a short period, usually up to 72 hours, for observation and evaluation if they are deemed a danger to themselves, a danger to others, or are gravely disabled, meaning they're unable to provide for their own basic needs like food, clothing, or shelter due to a mental illness. This 72-hour clock is not about curing anyone. It's about creating a window of safety. It's a pause button on the crisis. During this time, a team, usually including a psychiatrist, social workers, and nurses, will evaluate the person to determine the next appropriate step. The ER is the gateway, and from here the path splits into several different directions. One of the most common first stops after the ER is a place called a Crisis Stabilization Unit, or a CSU. A Crisis Stabilization Unit is exactly what it sounds like. It's a short-term, secure facility designed for people who are in an acute crisis, but who may not need the intensity or duration of a full inpatient hospital stay. You can think of it as a step above the ER, but a step below a psychiatric hospital. The goal here is rapid de-escalation. The environment is structured, monitored 24/7, and focused on getting the person through the immediate storm. Stays are typically very short, often just a few days to maybe a week. In a CSU, the focus is on medication management to stabilize symptoms, intensive group and individual therapy to develop immediate coping skills, and creating a solid discharge plan. It's a whirlwind of activity designed to get a person back on their feet and connected with outpatient resources, so they don't end up right back in the ER a week later. But what happens if the crisis is too severe for a short stay at a CSU? What if, after the 72-hour hold, the psychiatric team determines that the person is still a danger to themselves or others and needs a more secure, longer-term environment to truly stabilize? This is the point where the path leads toward inpatient psychiatric hospitalization. And this right here is where the map becomes incredibly complex and the choices or lack thereof can change everything. Because the term psychiatric hospital isn't one single thing. It's an umbrella term for a wide variety of facilities, each with its own mission, its own patient population, its own treatment model, and its own way of getting paid. You have psychiatric units inside of general medical hospitals, standing right next to the cardiology and oncology wards. You have large, standalone private psychiatric hospitals, some of which look more like college campuses, and may even specialize in things like eating disorders or addiction. And then you have the state-funded public hospitals, the institutions that have a long, complicated, and often stigmatized history in our country. Each of these doors leads to a profoundly different experience. The type of therapy offered, the staff-to-patient ratio, the daily schedule, the visiting hours, the level of freedom, it all varies dramatically. Understanding the fundamental differences between these places is the key to navigating what comes next. Choosing the right facility or simply understanding the facility you've been placed in can make all the difference between a positive, life-saving intervention and a traumatic, demoralizing experience. This first step in the journey, from the chaos of the ER to the decision point of hospitalization, is the most crucial. It sets the stage for everything that follows. Getting this part right, or at least understanding it, transforms you from a victim of the system into an active participant in your own or your loved one's care. But what actually happens behind the locked doors of an inpatient unit? What does a day really look like? What are your rights as a patient, especially if you're there involuntarily? And what is the real, unvarnished difference between a $100,000 private facility and the state hospital that so many people fear? We are about to walk through those doors and turn on the lights. Let's start with the most fundamental fork in the road, the one that determines almost everything about your experience from the moment you arrive. Are you walking in on your own 2 feet, or are you being brought in against your will? This is the crucial distinction between voluntary and involuntary commitment, and it's the legal bedrock of the entire system. Voluntary admission is exactly what it sounds like. You or your legal guardian recognize a need for intensive inpatient care. You go to a facility, fill out paperwork, and agree to be admitted for treatment. In many ways, it's like checking into a specialized hotel for your mind. You are there because you consent to be there. This gives you a degree of autonomy. The key word here is degree, because here's the catch that many people don't realize. Just because you checked yourself in doesn't always mean you can check yourself out on a whim. If you decide you want to leave, you typically have to give written notice. The clinical team then has a period of time, often 48 to 72 hours, to evaluate you. If they determine that you have become a danger to yourself or others, they can petition to change your status from voluntary to involuntary. So, while you hold the keys, the hospital can, under specific circumstances, change the locks. Now, let's talk about the one everyone fears: involuntary commitment. This is the scenario where you don't have a choice. It's a legal process where a person is hospitalized against their will because they meet a very specific and very high set of criteria. You've probably heard the terms on TV shows: a 5,150 in California, a Baker Act in Florida, a Section 12 in Massachusetts. Nearly every state has its own name for it, but they all function as a type of emergency psychiatric hold. To be placed on one of these holds, you generally have to meet one of 3 criteria. First, you are an imminent danger to yourself. This means there is a credible, immediate threat of suicide or self-harm. It's not about feeling sad. It's about having a plan and the intent to act on it. Second, you are an imminent danger to others. This involves direct threats or acts of violence toward another person, driven by a mental health crisis. And third, you are gravely disabled. This is a crucial and often misunderstood term. It means that, due to a mental illness, you are unable to provide for your own basic personal needs for food, clothing, or shelter. This isn't about being poor or homeless. It's about being so profoundly impaired by your condition that you cannot physically or mentally take the steps to keep yourself alive. An involuntary hold can be initiated by a law enforcement officer, a doctor, or a licensed mental health professional who has personally evaluated you. It's not something a family member can just decide to do on their own. The hold is temporary, usually lasting for 72 hours. This isn't a sentence. It's an observation period. The goal is to provide a safe, secure environment for immediate stabilization and a thorough psychiatric evaluation. During these 3 days, a team of professionals will assess your condition. At the end of the hold, one of 3 things happens. You might be released if you are no longer deemed a danger. You might agree to stay voluntarily to continue treatment. Or if the treatment team believes you still meet the criteria for commitment, they must go to court to petition a judge for a longer stay. This is a formal legal hearing where you have the right to a lawyer and the right to be present. The hospital has to prove to a judge that you are still a danger or gravely disabled. It's a civil liberties safeguard built into a system that has the power to take away your freedom. This brings us to the most important question of all. Once you're inside, what rights do you actually have? The answer, surprisingly, is a lot. Whether you are voluntary or involuntary, you do not check your humanity or your constitutional rights at the door. Every accredited mental health facility in the United States is required to provide you with a patient's bill of rights upon admission. First and foremost, you have the right to treatment. They can't just warehouse you. The facility must provide you with an individualized treatment plan designed to help you improve. You have the right to be involved in creating that plan. Second, and this is a big one, you have the right to refuse treatment, including medication. Now, this right is not absolute. If you are on an involuntary hold and are deemed to lack the capacity to make a sound medical decision, and your refusal of medication could harm yourself or others, a court can order you to be medicated against your will. But this is a high legal bar to clear and is not done lightly. For most patients, informed consent is the standard. They have to tell you what a drug is, its side effects, and the alternatives, and you have to agree. You also have the right to communicate with people outside the facility. This includes the right to make phone calls, send and receive mail, and have visitors during designated hours. They can't cut you off from the world. You have the right to confidentiality. Your presence there and your medical records are protected by HIPAA, just like at any other doctor's office. You have the right to be in a safe environment, free from abuse, neglect, or mistreatment from staff or other patients. And critically, you have the right to contact and speak with an advocate, an independent third party, often from a state-run protection agency, whose entire job is to investigate your complaints and ensure your rights are being protected. Understanding these rights is crucial, because they form the invisible rulebook for every single type of institution we're about to explore. So, let's start with the most common and recognizable one, the acute care psychiatric hospital. Think of this place as the emergency room and ICU of mental health. Its primary purpose is not long-term healing or deep therapeutic work. Its purpose is crisis stabilization. The goal is to take someone who is in an acute state of crisis, be it suicidal, psychotic, or manic, and get them to a point where they are no longer an immediate danger to themselves or others. The average stay is short, typically just 5 to 10 days. It's all about assessment, diagnosis, medication management, and safety. When you picture a psych ward, this is probably what you're thinking of. The doors are locked. The windows might be made of shatterproof plexiglass. The furniture is heavy and hard to move. In the bedrooms, there are no curtain rods, no long cords, no exposed pipes. The fixtures in the bathroom are ligature-proof, meaning they're designed to prevent anything from being tied to them. Your personal belongings will be searched, and items like belts, shoelaces, and drawstrings will be removed. This can feel dehumanizing and scary, but every single one of these measures is in place for one reason: to prevent suicide and self-harm. It is a total immersion safety bubble. Life inside is highly structured. A typical day starts with an early wake-up call, followed by breakfast and morning medications. The bulk of the day is then filled with group therapy sessions. These groups might focus on things like coping skills, anger management, mindfulness, or processing trauma. You'll also have a brief one-on-one check-in with your psychiatrist, usually to discuss how your medications are working. You'll meet with a social worker or case manager to develop a discharge plan, a roadmap for what happens when you leave, including follow-up appointments, therapy, and housing. Meals are at set times in a communal cafeteria. There might be some recreational therapy, like art or yoga, to break up the day. Evenings are for quiet time visitors and then lights out. It's a repetitive, contained, and intensely focused environment designed to remove external stressors and concentrate solely on stabilization. But here's where the path splits dramatically. While the core function of all these acute care hospitals is the same, the experience can be worlds apart. Is the group therapy led by a world-renowned PhD, or a newly licensed intern managing 30 people? Is your psychiatrist someone you see for 45 minutes a day, or 5 minutes twice a week? Is the food a balanced, chef-prepared meal, or a reheated tray of Salisbury steak? The answer to those questions often comes down to two simple words: private or public. The chasm between a for-profit, private-pay psychiatric hospital and a state-funded public facility is one of the starkest divides in American healthcare. It's a difference not just in amenities but in philosophy, resources, and ultimately in the kind of care you receive. And that is the critical difference we need to unpack next. Let's start with two hypothetical people, both in the grips of a severe mental health crisis. We'll call them Anna and Ben. Anna's family has a top-tier private insurance plan and the means to cover a substantial deductible. Ben has no insurance and has been relying on and off on Medicaid, but his paperwork has lapsed. Both need immediate inpatient care. This is where their paths diverge so dramatically, it's as if they've entered two different countries. Anna's journey begins with a phone call. Her family contacts a private psychiatric hospital, a place with a name that sounds more like a wellness retreat, something like the Serenity Grove or Clearview Meadows. They speak to an admissions counselor who is calm, reassuring, and walks them through the insurance verification process. An appointment is scheduled for that afternoon. When Anna arrives, she enters a lobby that resembles a nice hotel. There are comfortable chairs, soothing artwork on the walls, and a quiet, professional atmosphere. She meets with an intake team, a psychiatrist, a psychologist, and a social worker, in a private office for a comprehensive, 90-minute evaluation. They ask about her history, her goals, her fears. They are building a personalized treatment plan from the very first moment. By evening, Anna is settled into a private room with its own bathroom. The bed has a comfortable mattress. The window looks out onto a manicured lawn. A schedule is already posted on her door for the next day. Individual therapy, a group session on cognitive behavioral therapy, a meeting with a nutritionist, and an optional yoga class. The message is clear. You are here to heal, and we have a precise, resource-intensive plan to help you do that. Now let's look at Ben. Ben's journey begins in a hospital emergency room after being brought in by police who found him disoriented and in distress. He waits for hours, then days, on a gurney in a hallway because there are no available beds in the ER, let alone the psychiatric unit. This is a practice known as psychiatric boarding, and it's a national crisis. When a bed finally opens up at the county's public psychiatric hospital, he is transported there, often in restraints. He doesn't enter a serene lobby. He enters a sallyport, a secure, controlled entryway designed for safety and containment. The intake process is not a calm conversation. It's a rapid-fire assessment in a loud, crowded room, focused on two things. Is he a danger to himself or others? And what medication can stabilize him as quickly as possible? He is not asked about his long-term goals. The goal of the facility is clear and singular: crisis stabilization. Ben is then led to a ward he shares with 15 other men. The beds are cots lined up in a large, sterile room. The windows are covered with thick security mesh. There is one television bolted to the wall in a common area, and the noise is constant. His schedule for the next day is simple: medication call at 8 a.m., a large group meeting with 30 other patients and one overwhelmed social worker, and then long, unstructured hours of waiting. The message here is also clear. You are here because you are in crisis, and our job is to contain that crisis until you are no longer an immediate threat to public safety. This isn't just about comfort versus discomfort. It's about the fundamental philosophy of care. The private facility, like Anna's, operates on a model of holistic recovery. They have the funding and the staff to see the patient as a whole person. The treatment is multifaceted, combining medication management with intensive psychotherapy, skills-based learning, and complementary therapies. The staff-to-patient ratio is low. Anna might be one of just 6 patients assigned to her specific therapist, whom she sees daily. She has access to specialists, psychologists who excel in trauma therapy, dialectical behavior therapy, or OCD treatment. The entire environment, the therapeutic milieu, is designed to be part of the treatment. The quiet, the order, the healthy food, the structured activities, it's all meant to reduce stress and foster an environment where a person can actually begin to heal, not just exist. The public facility, where Ben is, operates on a model of acute stabilization. It is a system under immense, constant pressure. It's funded by state and county budgets that are perpetually strained. It serves as the safety net for the most vulnerable, the uninsured, the homeless, and those with the most severe and persistent mental illnesses, often complicated by substance abuse. The staff there are often incredibly dedicated, but they are fighting an uphill battle against a staggering lack of resources. The staff-to-patient ratio is dangerously high. A single psychiatrist might be responsible for the medication of 30 or 40 patients. A social worker might have a caseload of 20. Individual therapy is a luxury that is rarely, if ever, available. Ben won't get a one-on-one session to unpack his trauma. He'll get a 5-minute med check with a doctor in the morning. Group therapy isn't a small, focused session on specific skills. It's often a large community meeting that's more about managing the chaos of the ward than about therapeutic progress. The primary tool for treatment isn't therapy, it's psychopharmacology. The goal is to find a medication regimen that will reduce the acute symptoms, the psychosis, the mania, the suicidal ideation, to a level where the patient is no longer considered an imminent danger. Once that baseline is achieved, the pressure to discharge them is enormous, because that bed is desperately needed for the next person waiting in an ER hallway. This leads to another critical difference: the approach to discharge planning. At Anna's private hospital, her treatment team begins planning her discharge from the day she arrives. They coordinate with her outpatient therapist and psychiatrist. They hold family sessions to educate her loved ones on how to best support her. They might set her up in a step-down program, like a partial hospitalization or an intensive outpatient program, to ease her transition back into the world. They are building a bridge back to her life. For Ben, discharge is often an abrupt cliff. A social worker juggling that massive caseload does their best to find a placement, but the options are grim. A bed at a homeless shelter? A referral to an outpatient community mental health center with a 3-month waiting list for a therapist? Too often, patients like Ben are discharged with a bus token, a prescription for 30 days of medication, and a follow-up appointment weeks away that they may not have the resources or stability to keep. This is the origin of the infamous revolving door of the public mental health system. Patients are stabilized just enough to be released, but without the underlying issues being addressed or a supportive infrastructure in place, they decompensate, end up in crisis again, and are readmitted, starting the cycle all over. It's a system designed not for recovery, but for containment and release. So you have two parallel systems. One is designed for comprehensive healing and is accessible only to the privileged few who can afford it. The other is a chronically underfunded, overwhelmed system of last resort, designed to manage acute crises for the many who have nowhere else to turn. The quality of your care, the environment you're in, the therapeutic tools you're given, and your chances for long-term recovery are determined not by the severity of your illness, but by the size of your bank account or the quality of your insurance card. It's a brutal reality. Anna leaves with coping skills, a support network, and a plan. Ben leaves with a bottle of pills and the hope that they last long enough. And this brings us to the most uncomfortable question of all. We see the difference in the rooms, the therapy, the philosophy, but what is the actual tangible price tag on this chasm of care? What does it cost to get the kind of help Anna received? And what are the hidden costs to society for the kind of system Ben was forced to endure? The numbers are staggering, and they reveal the deepest, most broken part of America's approach to mental health. Let's start with Anna's bill. The kind of private, residential treatment she received, the one with individual therapy, group sessions, equine therapy, and 24/7 medical staff in a serene campus-like environment? The price tag for a 30-day stay often starts at $30,000, and it can easily climb to $60,000, $70,000, or even $90,000, depending on the facility and the intensity of the care. Let that sink in. $90,000 for 1 month. That's more than the median annual income for an entire American household. Now you might be thinking, what about insurance? And that's the great tragic illusion of the American healthcare system. Anna's family had good insurance, a premium plan through a major employer. But when they called the treatment center, they got the news that so many families get. We are an out-of-network provider. This is a critical piece of the puzzle. Many of the best, most effective mental health facilities in the country choose not to be in-network with insurance companies. Why? Because insurance companies dictate the terms of care. They'll say a patient only needs 10 days, not 30. They'll refuse to cover certain therapies they deem not medically necessary, even if a doctor says it's the only thing that will work. So these facilities opt out, allowing their clinicians, not a corporate spreadsheet, to decide what a patient needs. This means families like Anna's are forced to pay the entire staggering bill up front, and then spend the next year fighting their insurance company for partial reimbursement. They submit mountains of paperwork, they spend hours on the phone, they appeal denials, And if they're lucky, they might get 40 or 50% of their money back. If they're not, they get nothing. They're left with a life-altering debt, forced to take out second mortgages or drain their retirement savings, all for the privilege of getting their child the care they needed to survive. Mental health care at this level isn't healthcare. It's a luxury good, accessible only to the wealthy or those willing to bankrupt themselves for a chance at life. Now let's turn to Ben. What did his care cost? On the surface, it seems cheaper. Ben was on Medicaid, the government-funded insurance program for low-income individuals. His stay at the state psychiatric hospital was, from his perspective, free. His ER visits were covered. His brief interaction with the community mental health center cost him nothing out of pocket. So we're saving money, right? The public system is the fiscally responsible choice. That is a dangerous and profoundly expensive lie. The cost of Ben's journey is simply hidden, shifted onto different balance sheets. Let's follow the money. Each time Ben ended up in a psychiatric emergency room, a crisis team had to be mobilized. Doctors, nurses, and security guards spent hours, sometimes days, with him until a bed could be found. That single ER visit costs taxpayers on average between $2,000 and $3,000. Multiply that by the dozens of times it happened. Then there's the ambulance ride, another $1,000. The police response, which diverts officers from other calls, costs hundreds more per hour. When he was finally admitted to the state hospital, the daily cost to the state, to the taxpayer, is anywhere from $500 to over $1,000 per day. So his 2-week stay, while free to him, cost the public around $14,000. But here's the kicker. That $14,000 bought him little more than chemical stabilization in a chaotic environment. He was discharged with a handful of prescriptions and a follow-up appointment weeks away. The underfunded system had no resources for the intensive long-term therapy he needed. So, inevitably, the cycle began again. Another crisis, another ER visit, another police response, another hospitalization. This is what experts call the revolving door of mental health care, and it is an economic black hole. We spend a fortune to put out the fire, but we refuse to invest a dime in fireproofing the house. The real financial genius of this broken system is something called cost shifting. When the mental health system fails, the bill doesn't just disappear. It gets passed on to other, even more expensive systems. Think about it. Where do people like Ben often end up when they can't get care? Jail. A study by the National Alliance on Mental Illness found that nearly 1 in 4 people shot and killed by police have a severe mental illness. When they are arrested, they enter the criminal justice system. The cost of housing an inmate in a county jail can be over $100 a day. In a state prison, it can be $60,000 a year or more. And our prisons and jails have become, by default, the largest mental health providers in the nation. The Los Angeles County Jail, Rikers Island in New York, Cook County Jail in Chicago. These aren't just correctional facilities. They are massive, poorly equipped psychiatric institutions, warehousing hundreds of thousands of people whose primary crime was being sick in a country that refused to care for them. And the cost comparison is just brutal. The average cost for assertive community treatment, a proven model where a team of professionals provides comprehensive, wraparound services to someone like Ben in their own community, is about $20,000 per year. The cost to incarcerate that same person is $60,000. We are literally choosing to pay 3 times more for an outcome that is worse for the individual, worse for public safety, and worse for society. It is fiscal insanity masquerading as public policy. The costs don't stop there. When the system fails, people with untreated mental illness often end up homeless. They cycle through shelters, emergency rooms, and public spaces, which puts an enormous strain on municipal budgets and public services. The emotional and financial cost to families who become lifelong caregivers is immeasurable, leading to lost wages and their own declining health. And then there's the biggest number of all, the one that affects every single person in this country, whether you have a mental health condition or not. The cost of untreated mental illness to the U.S. economy. When you factor in lost productivity, disability claims, and the burden on our social systems, economists estimate the total cost to be over $400 billion a year. That's not a typo. $400 billion. We're not talking about the cost of providing care. We're talking about the cost of failing to provide care. So we have this perfectly broken system. A private tier that provides excellent care for a price so high it's morally indefensible, and a public tier so starved of resources that it creates a horrifying, expensive cycle of suffering. We are paying for this one way or another. We can pay up front for compassionate, effective treatment that allows people to become stable, productive members of society. Or we can keep paying double, triple on the back end through the crushing costs of police, jails, ERs, and lost human potential. The choice seems obvious, which leads to the real question: how did we get here? This two-tiered, profoundly flawed system wasn't an accident. Didn't just appear out of nowhere. It was built piece by piece over decades, by a series of deliberate decisions, landmark laws, and a profound, often fearful misunderstanding of the human mind. To understand how we can possibly fix this, we have to go back in time. We have to walk through the gates of the first asylums and uncover the shocking, forgotten story of how America's mental health institutions were born, and why, from the very beginning, they may have been destined to fail. To understand the dream, you first have to understand the nightmare. Before the asylum, in the sprawling young United States of the 18th and early 19th centuries, severe mental illness was a private catastrophe. There was no system. There was no safety net. There was only the family, the community, and the cold, hard floor of the county jail. If a son fell into a deep psychosis or a wife was consumed by a debilitating depression, the family was on its own. They were faced with an impossible choice. Some with heavy hearts would lock their loved ones away. In dusty attics, in damp cellars, sometimes chained to a wall for their own safety, or for the safety of others. It wasn't always born of cruelty, but of desperation. These were families trying to manage a situation they couldn't possibly comprehend, using the only tools they had: locks and chains. For those without a family, or whose family could no longer cope, the options were even grimmer. They became the wandering mad, shouting at phantoms on village greens, or they were rounded up and thrown into almshouses, poorhouses, lumped in with debtors, orphans, and common criminals. The most feared destination was the local jail. There, the mentally ill were not patients. They were inmates, often naked, living in their own filth, whipped into submission, and displayed for a jeering public who would sometimes pay a penny to see the lunatics rave. This was the baseline. This was the accepted reality. It was a world of hidden suffering and public spectacle. A world that viewed the mentally ill not as sick, but as subhuman, or worse, as sinners possessed by demons. But then, a revolutionary idea began to cross the Atlantic from Europe. It was a whisper at first, a radical philosophy that challenged centuries of dogma. It was called moral treatment. The core idea was shockingly simple, yet it would change everything. What if the mentally ill were not broken souls but people with sick minds? What if their illness was not a moral failing but a medical condition? And what if, and this was the most radical part, what if they could be cured? Cured not with bleeding, purging, or restraints, but with kindness, with respect, with clean air, good food, and meaningful work. The pioneers of moral treatment believed that if you removed a person from the chaotic environment that triggered their illness and placed them in a peaceful, orderly, and compassionate setting, their mind could naturally heal itself. It was a philosophy of profound optimism. In the United States, this idea found fertile ground among the Quakers. Guided by their principles of inner light and human dignity, they were horrified by the brutal conditions they witnessed. In 1813, they founded the Friends Asylum for the Insane, just outside Philadelphia. This wasn't a prison. It was a sanctuary. It was intentionally built to be beautiful, set on a sprawling 52-acre farm. There were no chains, no bars on the windows. Patients were called by their names, treated as guests, and encouraged to garden, read, and engage in quiet conversation. The goal was to rehumanize them, to restore their sense of self-worth. And the results were astonishing. People who had been written off as hopelessly insane began to improve. Some even recovered completely. Other small, private institutions followed this model, like the McLean Asylum in Massachusetts and the Hartford Retreat in Connecticut. They were beacons of hope, proving that moral treatment could work. But they had one major problem: they were expensive. They were exclusive sanctuaries for the wealthy, the well-connected. For the vast majority of Americans, the cellar, the almshouse, and the jail remained the only options. The nightmare continued for the poor. And that is where our story turns. It turns on the actions of one person. A woman who was not a doctor, not a politician, not a wealthy philanthropist, but a quiet, determined schoolteacher from Massachusetts named Dorothea Dix. In 1841, her life changed forever. She volunteered to teach a Sunday school class to female inmates at the East Cambridge Jail. What she saw there shattered her conscience. In an unheated, foul-smelling room, she found mentally ill women locked in cages, some naked, some chained to the wall, left to freeze in the bitter New England winter. When she asked the jailer why, he simply said that lunatics don't feel the cold. That single, callous remark ignited a fire in Dorothea Dix. She knew it was a lie, and she decided in that moment that she would dedicate her life to exposing the truth. So she began a journey, a crusade. For the next 2 years, she traveled thousands of miles on horseback, by carriage, and by train, crisscrossing the state of Massachusetts. She talked her way into every jail, every almshouse, every private home where the mentally ill were kept. She was a meticulous investigator, documenting everything she saw with a cold, clear eye. She recorded the filth, the darkness, the sounds of rattling chains and incoherent screams. She noted the names, the dates, the exact dimensions of the cages. She saw people flogged, starved, and left to fester in their own waste. She gathered a mountain of horrifying, undeniable evidence. Then, in 1843, she presented her findings to the Massachusetts state legislature in a document that would become known as her memorial. It was a bombshell. She wrote, not with angry rhetoric but with chilling factual detail. I proceed, gentlemen, briefly to call your attention to the present state of insane persons confined within this Commonwealth, in cages, closets, cellars, stalls, pens, chained, naked, beaten with rods, and lashed into obedience. She described a man in Danvers, confined in a cage in which he had been shut for years. He was naked. She told of a woman in Worcester County, who was a woman of wealth and rank, and who had enjoyed the advantages of education. She was now a raving maniac, chained to the floor. Her report was so graphic, so shocking, that many legislators simply refused to believe it. They accused her of exaggeration, of being a hysterical woman. But Dix had allies who confirmed her findings. The sheer weight of her evidence was too great to ignore. Public opinion was ignited. Shamed into action, the legislature voted to dramatically expand the state's mental hospital in Worcester, finally creating a place for the indigent mentally ill. But for Dorothea Dix, this was only the beginning. Massachusetts was not an anomaly. It was the norm. She took her crusade on the road, repeating her method in state after state. New Jersey, Pennsylvania, North Carolina, Illinois. She would arrive in a state, conduct her secret, tireless investigation, and then present another devastating memorial to the legislature. Her name became legendary. She was a force of nature, a one-woman army shaming a nation into confronting a truth it had tried to keep locked away. Over 3 decades, she was directly responsible for the founding or expansion of more than 30 state-run mental hospitals. She had single-handedly launched a national movement. This was the birth of the state mental hospital system as we know it. It was born from the noblest of intentions. It was a grand, optimistic, and profoundly humane experiment. The goal was to take the principles of moral treatment that had worked so well for the rich and make them available to everyone, paid for by the public good. The vision was a network of beautiful, state-of-the-art asylums, places of healing and refuge, scattered across the American landscape. For the first time, there was a belief that the government had a moral responsibility to care for its most vulnerable citizens. Dorothea Dix's victory seemed absolute. She had taken the suffering out of the shadows and built massive, brick-and-mortar monuments to compassion. But in winning this monumental victory, she had also sown the seeds of a new, and perhaps even greater tragedy. The dream of 1,000 small, intimate sanctuaries was about to be replaced by the reality of enormous state-run institutions. And what happens when a system designed for a few dozen patients is suddenly scaled up to house thousands? What happens when the fire of a moral crusade cools into the cold ash of state budgets and bureaucracy? The beautiful dream was about to collide with a very harsh reality. That collision wasn't a slow-motion crash. It was instantaneous and catastrophic. The first casualty was space itself. The Kirkbride plan, with its emphasis on single rooms and peaceful solitude, was predicated on a small, manageable patient population. But as states passed laws mandating the institutionalization of the mentally ill, the floodgates opened. The poor, the elderly with dementia, the difficult wives, the immigrants struggling with a new language and culture, they were all swept up in the same net, declared insane, and shipped off to the asylum. The numbers are staggering. An asylum designed for 250 patients was suddenly forced to house 1,000, then 2,000, then 5. The beautiful, airy single rooms were filled with 2, then 4, then 6 beds. Hallways became dormitories. Sun porches became wards. The very architecture designed to heal was now being used to warehouse human beings. The therapeutic community envisioned by Dorothea Dix and Thomas Kirkbride vanished, replaced by the grim reality of mass confinement. And with the crowds came the second casualty, money. State legislatures, happy to fund the construction of these grand monuments to public charity, were far less enthusiastic about funding their day-to-day operation. Budgets were slashed year after year. The ratio of staff to patients plummeted. A single doctor who was supposed to be providing intimate, personalized moral treatment was now responsible for hundreds, sometimes thousands of patients. They ceased to be physicians and became administrators, wardens of a sprawling, underfunded, and increasingly chaotic city of the mad. Nurses, once seen as moral guides, became little more than guards, their days consumed by crowd control and preventing riots. What does that actually look like? Imagine a ward built for 50 people, now crammed with 200. The noise is constant, a cacophony of moans, screams, and weeping that never stops day or night. The air is thick with the smell of unwashed bodies, stale food, and human waste. Patients are dressed in rough, identical smocks, their individuality stripped away. There is nothing to do. The books, the music, the farm work, all the core tenets of moral treatment are long gone. There aren't enough staff to supervise such activities. So people just sit. They sit on benches, they rock back and forth, they stare at walls, they lie on the floor. Days bleed into weeks, weeks into years, years into a lifetime. In this environment, hope doesn't just die. It's systematically suffocated. The institution, once intended as a temporary sanctuary for recovery, became a permanent destination. The diagnosis of insanity became a life sentence. Families, often ashamed or simply unable to cope, would drop off a relative and never return. The patient's name would be entered into a ledger, and they would effectively cease to exist to the outside world. They were no longer a person, they were a number, a bed, a mouth to feed. This was the era of the custodial asylum. The goal was no longer to cure, but simply to contain. To keep the mentally ill out of sight and out of mind. But even containment was proving impossible. With thousands of desperate, bored, and often terrified people crammed together, violence was inevitable. Patients attacked each other. They attacked the staff. The staff, overworked, underpaid, and frightened, fought back. Restraints became the primary tool of control. Leather cuffs, straitjackets, and muffs became standard issue. Patients could be chained to their beds or locked in seclusion rooms, tiny, dark, empty cells, for days or even weeks at a time. The asylum, the place of refuge, had become a prison. Faced with this utter failure, the medical community grew desperate. Moral treatment was clearly not working at this scale. They needed something faster, more efficient. Something that could be applied to hundreds of patients at a time. They needed a cure. And so, the focus shifted away from the mind and toward the body. The new theory was that mental illness wasn't a spiritual or psychological problem, but a physical one. A disease of the brain that could be attacked directly like any other ailment. This marked the dawn of what's known as the somatic or heroic era of psychiatry. The treatments that emerged from this period are the stuff of nightmares. Doctors began inducing seizures and comas, believing these violent biological shocks could somehow reboot a troubled brain. In insulin coma therapy, patients were injected with massive doses of insulin, sending them into hypoglycemic shock and a coma that could last for hours. They would often convulse violently, breaking bones or teeth, before being revived with a glucose solution. The process was repeated day after day for weeks. Then came metrazole shock therapy. A drug called metrazole was injected that induced an immediate, terrifyingly violent grand mal seizure. Patients were fully conscious as the seizure began, experiencing a sensation of impending doom before their body was racked with convulsions so powerful they would frequently fracture their own spine. The treatment was so traumatic that patients would beg and fight to avoid it. Even water, the gentle element of hydrotherapy in the moral treatment era, was weaponized. Patients were blasted with high-pressure hoses of ice-cold or scalding hot water. They were wrapped tightly in frozen, wet sheets and left for hours, a practice called cold packing, or submerged in tubs of near-freezing water until their body temperature plummeted. The rationale was that these extreme physical shocks would jolt the patient out of their psychosis. In reality, it was often just a brutal method of sedation and control. And then there was electroshock. Developed in Italy in the late 1930s, electroconvulsive therapy, or ECT, involved passing a current of electricity directly through the brain to induce a seizure. Early methods were crude and brutal. Patients were not given anesthesia or muscle relaxants. They were held down by a team of nurses while the current was applied, causing their body to arch and convulse violently, again, often resulting in broken bones and severe memory loss. These treatments seem barbaric to us now, and they were. But to the doctors of the time, they were a sign of progress. They were active, aggressive interventions. They were doing something. In the face of overflowing wards and human misery on an industrial scale, these violent cures offered a sliver of hope, a belief that science could conquer the chaos. They were searching for a silver bullet, a single procedure that could quickly and cheaply pacify a disturbed patient and, ideally, make them well enough to be sent home. They wanted a reset button for the human brain. And in 1935, a Portuguese neurologist named Agos Muniz believed he had found it. He had attended a medical conference where he learned of a procedure performed on chimpanzees. By destroying the connections in the frontal lobes of their brains, the chimps became placid and docile. Muniz had a chilling thought. What if the same could be done for humans? What if you could surgically sever the connections in the part of the brain responsible for complex emotion and thought? You couldn't just treat the illness, you could cut it out. He called his new procedure a leucotomy. But the world would soon come to know it by a different, more infamous name, the lobotomy. And an ambitious American physician named Walter Freeman was about to take this terrifying idea and turn it into a crusade. Walter Freeman was a man of immense ambition and unshakable self-belief. He wasn't a surgeon. He was a neurologist. But he saw in Muniz's leucotomy a ticket to medical stardom. He believed he had found the key to unlocking the mind, to curing the incurable. He partnered with a neurosurgeon, James Watts, and together they began performing the procedure in the United States, rebranding it with a more clinical-sounding name, the lobotomy. Their early work followed Muniz's method, drilling holes into the skull. It was messy, time-consuming, and required a full operating room and a surgical team. This was a bottleneck for a man like Freeman, who dreamed of a psychiatric revolution on a massive scale. He wanted a procedure that was fast, cheap, and could be done anywhere by anyone with a steady hand and enough conviction. He wanted to take the lobotomy to the masses. His moment of grim inspiration came from, of all places, his own kitchen. He recalled seeing a demonstration of how to sever brain connections through the eye socket on a cadaver. He took an ice pick from his kitchen drawer and began practicing on a grapefruit, and then on human cadavers. He discovered he could access the frontal lobes without drilling through the thickest part of the skull. He could simply go through the orbit, the thin bone at the back of the eye socket. The procedure he perfected was as simple as it was brutal. The patient would be rendered unconscious, usually through electroshock. Freeman would then lift the patient's eyelid, insert the long, slender instrument, which he called an orbitoclast, but everyone else called an ice pick, into the corner of the eye socket, right against the bone. Then he would take a small mallet and tap. Tap, tap, tap. A sickening crunch would signal the instrument had broken through the orbital plate and into the frontal lobe. He would then sweep the instrument back and forth, severing the connections between the frontal lobes and the thalamus, the part of the brain he believed was the seat of human emotion. Then he would pull it out and do the exact same thing on the other side. The whole thing took less than 10 minutes. This was the transorbital lobotomy, Freeman's ice pick lobotomy. It required no operating room, no surgeon, no anesthetic other than a jolt of electricity. It was an assembly line procedure for the human soul, and Freeman became its tireless traveling salesman. He bought a van, which he nicknamed the Lobotomobile, and began a decades-long road trip across the United States. He was a showman, a medical evangelist preaching the gospel of the lobotomy. He would roll into state hospitals, institutions packed to the rafters with patients considered hopeless. The staff, overwhelmed and desperate, often welcomed him as a savior. He'd line patients up and perform dozens of lobotomies in a single day, sometimes for an audience of doctors and nurses. He was famous for his theatrical flair, at one point developing a technique to insert picks into both eye sockets at once to save time. It was a macabre performance, a spectacle of medical hubris. His crusade wasn't limited to the backwards of forgotten asylums. He performed lobotomies in hotel rooms and on kitchen tables. His patients were not just the catatonic or the violently psychotic. They were soldiers back from the war suffering from what we would now call PTSD. They were artists and writers struggling with depression. They were restless housewives diagnosed with neuroses. They were even children. Howard Dully was lobotomized by Freeman at the age of 12, at the request of a stepmother who found him defiant. Freeman's diagnosis? Childhood schizophrenia. The evidence? Dully disliked his stepmother, was afraid of the dark, and once refused to go to bed. That was enough. The promise Freeman sold to desperate families was a simple one: peace. He couldn't promise a cure in the traditional sense, but he could promise that their loved one would be easier to manage. The violent would become placid. The anxious would become calm. The depressed would become simple. The procedure, he claimed, surgically severed the connection to their emotional pain. What it actually did was sever their connection to almost everything. The results were catastrophic. While a small percentage of patients showed some improvement in their primary symptoms, the cost was immense. The lobotomy didn't cure mental illness. It blunted the person. It stripped away their personality, their creativity, their ambition, their very essence. Patients were often left apathetic, emotionally vacant, and intellectually disabled. They became docile, childlike shells of their former selves. Freeman saw this as a success. A patient who could now sit quietly in a chair instead of screaming in a padded cell was, in his view, a victory. The family now had a manageable body, even if the person they knew was gone forever. Perhaps the most famous victim of this era was Rosemary Kennedy, the sister of President John F. Kennedy. In her early 20s, Rosemary was described as beautiful and vibrant, but she struggled with learning disabilities and mood swings that embarrassed her powerful, image-conscious family. Her father, Joseph Kennedy, worried that her sometimes erratic behavior could cause a scandal that would ruin the political ambitions of his sons. Without telling his wife, he turned to Walter Freeman. In 1941, at the age of 23, Rosemary Kennedy was strapped to a table. She was kept awake for the procedure, asked to sing songs and recite prayers so the doctors could gauge how much to cut. They kept slicing until she fell silent. The operation was a disaster. It left her with the mental capacity of a toddler, unable to walk or speak intelligibly. She was incontinent and spent her days staring blankly at walls. Her family, ashamed of what had been done, immediately sent her away to an institution in Wisconsin. Her existence was hidden from the public for decades. The vibrant young woman was erased, replaced by a terrible family secret. For nearly 2 decades, the lobotomy reigned as a mainstream medical procedure. Walter Freeman personally performed or supervised over 3,500 of them. He won accolades. Agos Moniz even won the Nobel Prize in 1949 for his initial discovery. It seemed this brutal solution was the only one available for the most severe forms of mental illness. But then, in the early 1950s, a discovery in a French laboratory would change everything. Researchers were testing a new anesthetic called chlorpromazine. They noticed it had a profound and unexpected side effect. It produced a state of calm and detachment in patients without rendering them unconscious. It seemed to quell the delusions and hallucinations of psychosis. The drug was brought to the United States and marketed under the brand name Thorazine. Its effect on the overcrowded asylums was immediate and revolutionary. For the first time, there was a non-surgical treatment that could manage the most severe symptoms of schizophrenia and other psychotic disorders. Thorazine was hailed as a miracle, a chemical lobotomy. It could do what the ice pick promised, make patients manageable, but without the irreversible brain damage. The arrival of Thorazine marked the beginning of the end for the lobotomy. It also signaled a monumental shift in psychiatry. The focus began to move away from physically restraining or altering the brain, and toward managing it with medication. This new psychopharmacological era would not only make the lobotomy obsolete, it would plant the seeds for emptying the asylums entirely, triggering a process that would become known as deinstitutionalization. The age of the massive, isolated institution was about to come to a close, giving way to a new and far more complex set of challenges for mental health care in America. The great emptying of the asylums began not with a single command, but with a powerful convergence of 3 forces: a medical breakthrough, a moral awakening, and a massive financial calculation. The first spark was chemical. In the early 1950s, a French pharmaceutical company developed a compound called chlorpromazine, marketed in the United States as Thorazine. It was originally intended as a sedative for surgery, but clinicians quickly noticed its profound effect on patients with psychosis. For the first time, there was a medication that could quiet the hallucinations, calm the agitation, and organize the thoughts of people with severe schizophrenia. It wasn't a cure, but it was seen as a miracle. The popular press dubbed it a chemical lobotomy. Suddenly, the idea that a person with a severe mental illness could live outside the walls of an institution, managed by a daily pill, seemed not just possible but inevitable. This medical optimism was supercharged by a powerful moral and legal movement. Riding the wave of the civil rights era, advocates for the mentally ill began to argue that indefinite confinement in a state hospital was a violation of fundamental human rights. Landmark court cases established the principle of the least restrictive environment, meaning patients had a right to be treated in a community setting if at all possible. Exposés continued to reveal the horrific, overcrowded, and abusive conditions inside the asylums, galvanizing public opinion. The moral argument was clear. These places were inhumane and had to be closed. But perhaps the most powerful driver of deinstitutionalization was cold, hard cash. State hospitals were colossally expensive to run, consuming huge portions of state budgets. At the same time, the federal government was creating new programs, Medicaid, Medicare, and Social Security disability insurance, that would help pay for care, but with a crucial catch. These federal funds could be used for nursing homes, for general hospitals, and for community clinics, but they were explicitly barred from being used in the large state-run institutions for mental diseases. The financial incentive was now perfectly aligned. States realized they could close their expensive, crumbling hospitals, discharge the patients, and shift the enormous financial burden of their care onto the federal government. It was a fiscal grand slam, a medical miracle, a moral crusade, and a financial escape hatch all pointed in the same direction. Out the front gates. The vision for what would come next was ambitious and noble. In 1963, President John F. Kennedy, whose own sister Rosemary had been tragically lobotomized, signed the Community Mental Health Act. The plan was to replace the massive, isolated asylums with a nationwide network of over 1,500 comprehensive community mental health centers. These would be the cornerstones of a new way of caring. They would provide everything a person could need to live successfully in the community: 24-hour emergency services, outpatient therapy, medication management, day programs, and short-term inpatient beds for crises. Care would be local, accessible, and humane. It was a beautiful, rational, and compassionate plan, and it almost completely failed to materialize. The funding required to build this new system never arrived. The escalating war in Vietnam and shifting political priorities starved the act of the money it needed. As the state hospitals began to shut their doors, releasing hundreds of thousands of patients, the promised network of community centers was a ghost system, a skeleton of what was intended. Patients were discharged from decades of structured confinement into communities that had neither the resources nor the understanding to support them. The result was a human catastrophe played out in slow motion. Without the safety net of the community centers, many former patients stopped taking their medication. They lacked housing, employment, and the basic life skills needed to survive on their own. They became caught in what experts call the revolving door syndrome, a miserable cycle of homelessness, brief stays in emergency rooms, and encounters with law enforcement over and over again. The problem of severe mental illness hadn't been solved. It had just become invisible, pushed out of the isolated asylum and onto the streets of every city in America. The old centralized system, for all its monstrous flaws, was shattered. But it wasn't replaced by a new, better system. It was replaced by a chaotic, fragmented, and chronically underfunded non-system. And this is the landscape we live in today. The types of institutions that exist now are a direct consequence of this great upheaval. The most direct successor to the old asylum is the modern acute psychiatric hospital, or more commonly, a psychiatric unit within a general hospital. But its function is radically different. The goal is no longer long-term care or custody. The goal is short-term stabilization. When a person is in an acute crisis, a danger to themselves or others, they can be brought to one of these units, often on an involuntary hold, commonly known as a 72-hour hold, or by its legal code like a 5150 in California. The entire focus is to manage the immediate crisis, adjust medications, and develop a safety plan for discharge. The average length of stay is not decades or years, but typically just 7 to 10 days. They are a critical pressure release valve for the most acute emergencies, but they are designed to get people in and out as quickly as possible, pushing them back into that patchwork of community care. They are not, and were never intended to be, a solution for the underlying illness. But as this new fractured landscape took shape, a far darker and more disturbing type of institution began to take on the role of the old asylum. As hundreds of thousands of people with untreated mental illness ended up on the streets, their symptoms were no longer seen as medical issues, but as criminal ones. Behaviors like sleeping in a park, yelling at unseen voices, or shoplifting food became crimes like trespassing, disorderly conduct, or petty theft. Police became the de facto first responders for mental health crises. And so, the new asylums became the nation's jails and prisons. The numbers are staggering and shameful. Today, the three largest mental health providers in the United States are not hospitals. They are the Los Angeles County Jail, the Cook County Jail in Chicago, and Rikers Island Jail Complex in New York City. There are more people with severe mental illness in our jails and prisons than in all of our remaining state hospitals combined, by a factor of 10. Through the catastrophic failure to build a functioning community care system, we inadvertently created a new pipeline, one that leads directly from the psychiatric crisis to the prison cell. For a huge and growing number of Americans, the place for the mentally ill is no longer a hospital ward, but a concrete block. This criminalization of mental illness is the most profound and tragic legacy of deinstitutionalization, creating a system where punishment has replaced treatment. But this is only part of the new reality. Other institutions did rise up to try and fill the gaps, creating a complex spectrum of care that sits between the short-term hospital stay and the long-term prison sentence. This new landscape is a patchwork quilt, stitched together out of necessity, desperation, and flashes of genuine innovation. To understand it, you have to move beyond the image of a single monolithic institution and instead picture a ladder of care, with different rungs for different needs. At one end of this spectrum, designed for those who need more than a weekly therapy session, but less than a locked hospital ward, are residential treatment centers or RDCs. Imagine a teenager. Let's call him Alex. Alex is spiraling. His depression and anxiety have led to self-harm and an inability to even attend school. His family is at a loss. Outpatient therapy isn't enough, but a psychiatric hospital feels too extreme and is only meant for short-term crisis stabilization. For families like Alex's, an RDC can seem like the only viable answer. These are live-in facilities often located in quiet, campus-like settings where individuals, frequently adolescents, but also adults with specific issues like eating disorders or severe substance abuse, can receive intensive, structured care for months or even years. The philosophy behind an RDC is total immersion. The outside world, with all its triggers and stressors, is temporarily removed. In its place is a highly controlled environment. The day is meticulously scheduled. Group therapy after breakfast, individual counseling before lunch, classroom instruction in the afternoon, followed by recreational or skills-based activities. It's a holistic approach, aiming to treat the individual's psychological wounds, while also teaching them the coping mechanisms and life skills they'll need to function once they leave. For some, this intensive, insulated environment is life-saving. It provides the time and space to heal that a chaotic home life or a revolving door hospital system simply cannot. However, the world of residential treatment centers is deeply controversial and fraught with problems. This is the heart of what's often called the troubled teen industry, a multi-billion-dollar-a-year business with wildly inconsistent oversight. While many RDCs provide excellent, compassionate care, others have been exposed for abusive practices, employing unqualified staff and using punitive measures disguised as therapy. And the cost is astronomical. A stay can run tens of thousands of dollars a month, creating a two-tiered system where quality long-term care is often a luxury reserved for the wealthy. For countless families, the choice isn't between a good RTC and a bad one. It's between an unaffordable RTC and nothing at all. Moving further along the spectrum of care, we find another critical piece of the puzzle: the group home. If an RDC is about intensive, isolated treatment, a group home is about supported community integration. These are typically smaller, residential houses, located right in the middle of a normal neighborhood. They're designed for adults with serious and persistent mental illnesses, like schizophrenia or bipolar disorder, who are stable enough to not need hospitalization, but still require daily support to live safely and independently. Think of someone we'll call Maria. Maria has spent years in and out of state hospitals. When she's discharged, the lack of structure is overwhelming. She forgets her medication, struggles with cooking and budgeting, and becomes isolated, often leading to another crisis and another hospitalization. A group home is designed to break that cycle. Here, Maria lives with a small number of other residents and one or two trained staff members. The staff aren't there to be guards or doctors, but to act as coaches and a safety net. They help residents remember their medication, assist with meal planning and grocery shopping, and provide transportation to appointments or part-time jobs. The core goal of a group home is to foster autonomy. It's a step-down model, a bridge between the total dependence of an institution and the total independence of living alone. It provides a crucial layer of support that was completely absent in the era of deinstitutionalization. When the asylums closed their doors, they sent people like Maria out into a world with no safety net. Group homes, at their best, are an attempt to weave that net one house at a time in the very communities where people belong. But like RDCs, the reality is inconsistent. Funding is a constant struggle, leading to underpaid staff and high turnover. And the not in my backyard phenomenon, or NIMBYism, means that communities often fight viciously to prevent group homes from opening, further stigmatizing residents and limiting the availability of this vital resource. Beyond these broader models, the modern landscape has also given rise to highly specialized facilities. The one-size-fits-all approach of the old asylum is gone, replaced by a recognition that different conditions require different environments. We now have dual diagnosis centers, created specifically to tackle one of the most complex challenges in mental health: co-occurring substance abuse and mental illness. For decades, these two issues were treated separately. You'd go to one place for your depression and another for your alcoholism, with neither facility equipped to handle the way these conditions feed off each other. Dual diagnosis centers integrate both treatments under one roof, understanding that you cannot successfully treat one without addressing the other. Similarly, there are residential facilities dedicated exclusively to treating severe eating disorders, where patients receive intensive medical monitoring alongside psychological therapy to rewire their relationship with food and their body. There are trauma and PTSD centers, often for veterans or survivors of profound abuse, that use specific evidence-based therapies in a safe, contained setting. This specialization is a major advancement. It allows for a depth of expertise and a tailored environment that was impossible in the old state hospitals, which had to be a jack of all trades and consequently a master of none. So the new system isn't a single thing. It's an ecosystem of care, a continuum. At one end, you have the emergency room and the crisis stabilization unit for immediate, short-term intervention. From there, a person might step up to an inpatient psychiatric hospital for more intensive care. After stabilization, they might step down to a month-long stay at a specialized residential facility, followed by a transition to a community-based group home for 6 months, and finally, to living independently with the support of an intensive outpatient program. In theory, this creates a seamless journey toward recovery, with each step providing the precise level of support needed at that moment. But we don't live in theory. We live in reality. And in reality, this complex, fragmented system is riddled with cracks. The biggest crack of all is access. Having a diverse array of institutions doesn't matter if people can't get into them. Every step of that ideal journey is a battle with insurance companies who deny claims for residential treatment they deem not medically necessary. A battle with waitlists that are months or even years long for a bed in a state-funded group home. A battle with geography, where someone living in a rural area might be hundreds of miles from the nearest specialized facility. This leads to one of the most tragic and frustrating phenomena of the modern system: the revolving door. A person in crisis is admitted to a hospital. They are stabilized on medication over a week or two, and then discharged because the insurance company will no longer pay for the bed. But the RDC they need has a 6-month wait list. The local group home is full. The intensive outpatient program isn't covered by their plan, so they're sent home with a handful of prescriptions and a follow-up appointment a month away. Without the necessary support structure, they begin to decompensate. The cycle repeats. They fall back into crisis, end up back in the emergency room, and are readmitted to the hospital. They are trapped in a system that is excellent at managing acute emergencies, but often fails at providing the meaningful long-term care that leads to lasting recovery. We've built a system of disconnected islands of care, and for too many, there are no bridges to get from one to the next. This fragmentation isn't just an inefficiency. It's a fundamental design flaw that costs lives. When a person is discharged from a crisis unit with a handful of pamphlets and a 2-month wait for an outpatient appointment, we haven't solved their crisis. We've just postponed it. So what's the answer? How do we build the bridges between these islands of care? The most promising solution, and the future of mental health care in America, lies in a concept called integrated care. The idea is revolutionary in its simplicity. Treat the mind and the body together in the same place at the same time. For decades, we've acted as if the head is disconnected from the rest of the body. You see a cardiologist for your heart, an endocrinologist for your diabetes, and a psychiatrist for your depression, often in different buildings in different health systems with records that don't talk to each other. Integrated care demolishes these silos. It means placing mental health clinicians directly into primary care offices. It means when you go for your annual physical, your doctor can also screen you for depression and, if needed, walk you down the hall to speak with a therapist immediately. This model does more than just offer convenience. It attacks the very foundation of stigma. When mental health care is just another part of your regular doctor's visit, it's no longer this scary separate thing. It's just health care. It also leads to vastly better outcomes. We know that chronic physical illnesses like diabetes or heart disease are incredibly difficult to manage if a person is also struggling with untreated depression. By addressing both simultaneously, patients are more likely to take their medications, follow their treatment plans, and see improvements in both their physical and mental well-being. One of the most effective versions of this is the collaborative care model. In this system, your primary care doctor works as a team with a behavioral health care manager and a psychiatric consultant. The patient interacts mostly with their trusted family doctor, while the whole team works behind the scenes to manage their care, adjust medications, and provide therapy. It's a way to leverage the expertise of psychiatrists, who are in short supply, across a much larger population of patients, all within the familiar setting of a primary care clinic. On a larger scale, we're seeing the rise of certified community behavioral health clinics, or CCBHCs. Think of these as a one-stop shop for comprehensive mental health and substance use treatment. They are required by law to provide a full range of services, from 24/7 crisis intervention to outpatient therapy, medication management, and even primary care screening and monitoring. They are designed to serve anyone who walks in the door, regardless of their ability to pay. It's a model built not around a specific diagnosis or level of acuity, but around the needs of the whole person and the entire community. This is a direct, systemic attempt to build the bridges we so desperately need. And of course, we cannot talk about the future without talking about technology. The pandemic forced a massive, unplanned experiment in telehealth, and in many ways, it has permanently changed the landscape of mental health care. For someone living in a rural area, hours from the nearest therapist, or for a single parent who can't find or afford childcare, video appointments aren't just a convenience, they're a lifeline. Telehealth has shattered geographical barriers, making it possible to connect with a specialist halfway across the country, and making it easier for people to take that first, difficult step of seeking help from the privacy of their own home. But technology is not a cure-all. The digital divide is real. Millions of Americans lack reliable internet access, or the devices needed to connect. There are also complex legal hurdles around licensing, which often prevent a therapist in one state from treating a patient in another. And for someone in a deep, acute crisis, a video call may be no substitute for in-person, human connection and a safe therapeutic environment. The future isn't about replacing in-person care with technology, but about using technology to augment it, to fill the gaps, and to create more entry points into the system. So after this deep dive into the complex, often broken, and yet evolving world of mental health institutions, the most important question remains. What can you do? If you are the one struggling, please know this. Your struggle is valid and you are not alone. The system is daunting, but it is not impenetrable. Your first step doesn't have to be walking into a psychiatric hospital. It can be as simple as telling your primary care doctor how you've been feeling. They are an incredible gateway to resources and can be your strongest ally. You can also call or text 988, the Suicide and Crisis Lifeline. It's not just for people who are actively suicidal. It's a resource for anyone experiencing any kind of mental health distress. They are free, confidential, and available 24/7 to connect you with trained counselors and local resources. Websites like the National Alliance on Mental Illness, or NAMI, and SAMHSA have treatment locators that can help you find care near you. The most courageous thing you can do is to be your own advocate. Ask questions. If you don't understand a diagnosis or a treatment plan, say so. If a medication isn't working or has side effects you can't tolerate, speak up. You are the foremost expert on you. If you are a friend, a parent, a spouse, or a child of someone who is struggling, your role is just as critical. The best thing you can do is listen without judgment. Create a safe space for them to be honest about their pain. You don't need to have the answers. You just need to be present. You can offer practical help. Help them research treatment options, offer to drive them to an appointment, or sit with them while they make that first phone call. But remember to take care of yourself too. Supporting a loved one through a mental health crisis can be emotionally draining. Seek out your own support, whether it's through therapy or support groups for family members. You cannot pour from an empty cup. And for all of us as a society, our work is to continue to tear down the walls of stigma. We do this by talking openly. We do this by sharing our own stories when we feel safe to do so. We do this by challenging misinformation, and by gently correcting a friend who uses outdated, pejorative language. We do this by voting for policies and politicians who prioritize mental health care funding and reform. We must demand a system that treats mental illness not as a moral failing or a character flaw, but as what it is: a health condition deserving of the same compassion, urgency, and quality of care as cancer or heart disease. The story of mental health care in America is one of great contrast, of incredible scientific progress and devastating systemic failure, of profound compassion and heartbreaking neglect. We have explored the locked wards of state hospitals, the revolving doors of emergency rooms, and the quiet, hopeful spaces of outpatient clinics. We've seen a system that is flawed, fragmented, and frustrating, but it is not without hope. Hope lives in the innovative models of integrated care. It lives in the new technologies connecting people to help. It lives in the tireless work of peer support specialists who have walked the path themselves. And most importantly, it lives in you. It lives in the courage to seek help, the compassion to offer it, and the collective will to demand something better. The path to healing for an individual and for our nation begins not in the sterile halls of an institution, but in the simple, profound, and unbreakable power of human connection.